Good afternoon and good morning to our audience from Asia. My name is Jianan Yang, and I'm the postdoc fellow at the Asia Health Policy Program here at the Schornstein Asia Pacific Research Center. So today, we are delighted to have Dr. Daniel Bennett talking to us about the links between depression and poverty in India. And Dr. Daniel Bennett is an economist at the Center for Economic and Social Research and the Department of Economics at the University of Southern California. He studies economic development and global health in Africa and South Asia. Dr. Bennett's recent work examines the relationship between poverty and poor mental health, as well as the indirect consequences of the HIV/AIDS epidemic in Sub-Saharan Africa. And other work of him considers sanitation and hygiene behavior and the organization of pharmaceutical markets. Dr. Bennett collects primary data and uses both experimental and quasi-experimental methods, and he received his PhD in 2008 from the Brown University. Without further ado, Dr. Bennett, the floor is yours.
Hi, everybody. Thank you so much for joining me today. I appreciate your attention. And thank you for inviting me, Jenan. I really appreciate the opportunity, and it's really nice to be with you today and tell you a little bit about the topics that I work on. I'm an economist at the University of Southern California, and my recent work has tried to examine the relationship between depression and poverty, and I work mostly in South Asia, and so this the context I'm most familiar with is India, although I hope to begin by motivating this topic with a kind of more general discussion of why we should care about the mental health from the standpoint of economic development and the economic lives of poor people. And so I focus on depression. And why should we focus on depression? I mean, I guess the answer for a development economist, you know, there's lots of problems out there. There's lots of things that someone might want to study, but the depression is interesting because it is so pervasive. So something like 15 to 20% of people experience depression in their lifetimes, and it's the fourth largest contributor to the global burden of disease. And so it's the most common mental disorder. It's very, very common, and many people are experiencing it. And so we want to understand how experiencing depression affects the way people make decisions, the way they work, and the way their economic outcomes are realized. And so if you think about the potential connections that there could be, the symptoms of depression include fatigue, anhedonia, which means flat affect, pessimism, disrupted sleep and nutrition. Each of these potentially could influence economic behavior through labor supply, through productivity, through investments in child education. So there's a lot of potential linkages there. And while there's a rich, of course, literature in medicine and in public health about depression, there are limitations of what this literature has looked at in the context of low and middle income countries and the relationship between depression and poverty. And so, as I said, depression is very common. It's more common among the poor. And so that raises a question of what's driving that relationship, and there may be multiple linkages that cause that correlation to be there. What we're interested in specifically is the way in which depression may contribute to poverty and may make it so that you kind of pass along poverty to your children, or there may be intergenerational effects. To give you a sense, I mean, this kind of relationship between depression and poverty you can see in a lot of data, but I have one data source that we collected that kind of illustrates it nicely, which is that we did a representative sample of people in the Madhugiri district of Karnataka, which is near Bangalore. And this was intended to be representative, so we made an effort to collect, to reach out to people even if they weren't home and try to collect a representative sample. We measured depression severity, demographics, and socioeconomic status. And then we created an index of socioeconomic status in order to relate this to depression severity. What we saw was that if you look on this chart on the left, something like 24% of people had at least mild depression in this context, and that would be defined by having a PHQ-9 score of 5 or more. And then about 9% had a score of about 10 or more, which would be consistent with major depressive disorder. I want to emphasize that this is not a diagnosis. This is just a score on a screening scale that is roughly consistent with that level of severity. And then when we relate the score to our SES index, and this is within a sample of people who are relatively poor, you see that the people at the lowest end of the SES distribution have scores that are over double the scores of people at the high end of the distribution. And so there's this strong correlation between depression and poverty. The kind of average effect that I've talked about, also you can see in other subgroups. And so the kind of relationship between depression and economic outcomes may be particularly important when you're looking at subgroups where you expect depression to be extremely elevated or where you expect there to be a lot of psychological distress. So if you think of refugees, trauma victims, people who live in conflict areas, people who have experienced natural disasters, these sorts of things, the depression rates could be quite high in those settings, such you may have a majority of people or something that would be depressed in those subgroups. And so you don't actually need to look to kind of these exotic situations to find people who are depressed. There's a nice paper by Banerjee et al. 2022 that looks at depression among older adults in Tamil Nadu, India. And the older adults have elevated rates of depression for several reasons, but they face increasing physical and cognitive impairments, and many of them live alone. And so these risk factors for depression are especially high for them. And the authors, this is a chart from the authors that shows by age and by gender rates of depression. Their study from Tamil Nadu is there in I guess it's sort of hard to see, but it's the dotted line here. But they've also looked across other countries, and you see, like, if you're over 70 years old, rates of depression are like 40 or 50%. And so that just shows you, if you look at these subsamples of people, depression is quite extreme in some of them. So there is a policy challenge related to poor mental health in developing countries. And there's kind of two sides of it. So I want to describe the first side, which is that there are many fewer providers of mental health care in low and middle income countries compared to industrialized countries. And so this chart here is by Saxena et al. 2007, and it shows by income category, the number of different types of mental health care providers per 100,000 people in high income countries, and then going down to low income countries. And it's just striking how there are so much fewer people providing mental health care in poor countries. And so that is sort of, it's striking, but it also has an implication, which is that if we're trying to provide mental health care in this context, how do you scale interventions without more human capital? And so people have proposed solutions. One popular approach is to train lay counselors. So people who live in the community, can you sort of give them basic training in how to provide counseling and in sort of simplified versions of cognitive behavioral therapy? And that's a possibility. Another approach is to try to standardize therapy by doing it in group settings and using recordings. And so you can kind of really control what is being said. And so anyway, that's one side. But I think the other side of this is that there is low demand for mental health care. There's limited awareness of mental illness. People do not realize that the symptoms they're experiencing are related to psychological distress. And on top of that, the level of stigma related to mental illness is extreme. And I know best the context of India, where you do not want to be seen in your village as someone who has a mental disorder, and the implications of that in terms of being shunned, having difficulty finding employment, having difficulty getting married, I would say, I don't know that this has been quantified rigorously, but it seems to me are quite much more extreme than what we would experience in the United States. And also that like the village context that many people live in doesn't give people privacy. So everybody knows if you're going to see a provider of mental health care, and people gossip about it. And so there's kind of that dynamic that we don't have in at least where I live. And so there's a kind of two-sided challenge here, where it's not clear how to scale mental health treatment when you don't even have people don't necessarily want it, and when policymakers don't have the manpower to provide it in any case. So now I want to also just to spend a minute summarizing what we know about mental health treatment in low and middle income countries. And so the first kind of bigger point to make about this is that the most mental health research, like a lot, like maybe 80 or 90% of mental health research is done in industrialized countries. And so we don't have a very good evidence base of what happens for mental health treatment in poorer countries. And that is important because these issues, like the kind of severity of illness, the causes of illness, the ability to get treatment of the healthcare systems are really different across these settings. And so it's problematic to try to cross-apply the industrialized country estimates and say, oh, well, then we understand what will happen in a low and middle income country. So that being said, I want to flag two meta-analyses that are about the impact of treatment. And so the Gartlander, I always trip over that name, the Gartlander meta-analysis is looking at pharmacotherapy, and which is what I'll be describing, which is the work that we've done. And so that's why I bring it up. And so this is treatment with SSRIs for depression. And so they say that across the existing studies reduces depression severity by about 0.35 standard deviations. These are always expressed in standard deviations. And that cognitive behavioral therapy, which is the leading psychotherapy approach to depression treatment, has a similar effect on average to pharmacotherapy. That's not developing countries. That's wherever they can find estimates for pharmacotherapy. And I don't believe there is a meta-analysis of developing countries' pharmacotherapy. The Singla et al. Paper is about low and middle income countries, but it focuses on psychological interventions. And so they say that across common mental disorders, and so therefore not just depression, the impact of psychological interventions is around 0.49 standard deviations. So that's sort of what we know about the treatment effects on health of these approaches. There's another paper that's interesting that is a meta-analysis of economic impacts of treatment for mental illness. And so that's by Lund et al. And it's very recent, so I think it hasn't been published yet. But it aggregates all the low and middle income country mental health trials and looks at all the times that the researchers measure economic outcomes. And so, maybe they would measure whether you're able to go to work, or how much time you spend at work, or whether you are going to school. And they kind of aggregate across those and distinguish between work-related and other outcomes. And I've taken this table from their paper, and it's just showing in column 1 their aggregate effects, which are measured in standard deviations. And so, for instance, the main effect here would be across all of their interventions, the mental health treatment is improving economic outcomes by 0.15 standard deviations. And so if you're interested in understanding that, I think this is a great resource to look at. So with that being said, I want to turn to some of the work that I've done with, and this is all with my longtime co-author, Manuela Angelucci, who's at University of Texas at Austin, and definitely we share definitely credit and blame for all of this. And so what we did was implement a community-based cluster randomized trial of pharmacotherapy for depression in an area outside of Bangalore, India. We screened adults in the community for depression using a door-to-door screening instrument. So we went door to door and we talked to approximately 5,500 people. And with that sample, we were able to recruit 1,000 adults with mild or moderate depression symptoms. Within this group, we cross-randomized 2 interventions, pharmacotherapy and livelihoods assistance. And I'll describe these interventions in more detail in a minute. And then over the course of 26 months, we assessed impacts on depression, as well as a range of socioeconomic outcomes and several potential pathways, the ways that we thought that the depression might be connected to these socioeconomic outcomes. The psychiatric care or PC intervention involved collaborating with a local social service organization and a local hospital. And so we arranged so that patients in our study who were randomized to receive this intervention could get 8 months of free pharmacotherapy for depression. This was conducted by psychiatrists at the hospital. And I wanted to emphasize that the psychiatrists made the decisions about treatment and diagnosis, and that the economists were not the ones trying to provide treatment in this case. We just facilitated this interaction with the doctors. And so patients had an initial visit, which typically lasted 30 minutes, in which the provider would explain mental illness and develop a treatment plan, and then monthly follow-up visits for up to 8 months, where they would monitor progress and side effects. This was overseen by multiple IRBs. In particular, the hospital that we worked with had an IRB that oversaw the intervention and made sure that it was done appropriately. The other intervention that we offered was called livelihoods assistance. Livelihoods interventions are a class of economic intervention that are attempting to improve people's socioeconomic status by giving them economic opportunities, but in a more tailored or customized way. So, you know, it's not just giving you a job, it's trying to talk to you about what might help you improve your livelihood and give you that. And so some people got training, some people got small loans, some people got placed in jobs in factories that are nearby. And so it was customized to the person. And our thinking with this was that, well, and also the organization that we work with has this idea that in order to achieve lasting improvements in mental health, you have to not just provide treatment, but also improve the person's socioeconomic situation to take away some of the risk factors that make it so that someone could, you know, would be at greater risk of depression. And so we wanted to combine these things and test this model. So we cross-randomized these. So patients either got psychiatric care and livelihoods assistance, psychiatric care only, livelihoods assistance only, or a control group. And the control group was twice as large as the other arms. And the reason for that was because the NGO that we worked with had a capacity constraint that they can only serve so many people, but we had the budget to expand the control, which helped us improve statistical power. The timeline looked like this. We have baseline and then 4 follow-up rounds. And the important thing is that there's these rounds 2 and 3 are happening while psychiatric care was ongoing, and rounds 4 and 5 are happening after it has concluded. And so in the way I show you the results, I'm going to distinguish between rounds 2 and 3 and call that during the PC intervention, and rounds 4 and 5 and call that after the PC intervention. And so I'll just show you several sets of results. There's a lot in there, and you can look through the paper to see more, but these are the main headline findings, I think. And so the first one is just to think about the impact on depression. And so you can see this here where in the left panel, as I said, during the PC intervention, and then on the right after the PC intervention, and I've just plotted the densities of PHQ-9 scores indicating depression severity across the 4 arms. And the striking thing you see is that for people who received both the PC and LA interventions, they have a but substantially lower PHQ-9 scores than people in the control arm. The other arms, the PC only or the LA only, have slightly lower scores. PC is significantly different than control, but LA is not. And then when you go to the after period, and so now we're 18 to 26 months later, and you see that the people who got PC and LA continue to have better mental health than the control, but the other arms do not. And so this opens a lot of doors for what we're going to do next, because if we hadn't gotten impacts on mental health, then, well, what else can we say about the relationship between mental health and economic outcomes? But because we have this, it helps us understand, like, what are the secondary impacts of improving mental health. And so one of the biggest findings that we have is that there's an effect on child human capital investment. So here, let me motivate this a little bit. There's a large literature in child development that links depression to less investment in children, worse parenting, across a range of outcomes. There's another economic study that also shows an impact on child investment. And so this is a linkage that is not, it's good to see that it's here, and we're building up evidence that this is an important relationship. And we're not the only ones to show it. So what we see here is this is looking in the period after the PC intervention. And don't worry about this ANCOVA-LASSO stuff is more complicated than you need to know for this purpose. But if you look here, especially in the PC intervention, we see these positive effects, and we can't reject that the effects are the same across the other interventions as well. Now, these are not that strong. When you go over here to the right and you look at the children who are older, then you see effects that are quite a bit larger. And so here, the PCLA and PC interventions are increasing this child investment index by 0.4 to 0.45 standard deviations. This index consists, I should have said, is an index that's based on enrollment, attendance, homework, and the absence of child labor. And the things that are really driving it are increases in enrollment and reductions in child labor. And the fact that effects are bigger for older kids is important, because they're the ones who are more marginal for dropping out of school. And so showing that they remain in school longer because of this means that they probably are going to end up with more lifetime schooling than completed schooling than if this were happening at younger ages. And I guess another thing to say about this is that if you compare this to other interventions that directly try to improve child human capital, and the famous one that economists always talk about is the Progresa conditional cash transfer program in Mexico. And these are in the same order of magnitude as that sort of program. So these are substantial effects. Another finding that we have is that the livelihoods intervention may be protective in the short term. And so the livelihoods intervention actually doesn't do quite what you would think. And so here is the impact of these interventions on hours, so hours of work per week, and earnings per week. And so one thing to see is that if you just look here at livelihoods, it's not actually increasing earnings on its own or increasing work. So it doesn't do what you would think, like, oh, now these people are working more and earning more. There doesn't seem to be that effect, which is going to create a puzzle, because I just told you, okay, if I combine PC and LA, the biggest impacts on mental health happen for that group. And so livelihoods is doing something that is not so straightforward. It's a very light touch intervention. It involves a few meetings and counseling sessions with not counseling is the wrong word, but consultations with a person helping you find a job or helping you develop a new skill. And so it doesn't cost very much, and it didn't actually improve their livelihoods, is what this says. On the other hand, if you look at another way, see that the PC intervention has this negative short-term impact on the number of hours that they work. We don't have a definitive explanation for this. My favorite explanation is that this may be related to stigma, and that people don't want to be seen out and about because receiving pharmacotherapy is stigmatized, and in order to work, you have to do that. But if you also get LA in this top line here, there is no negative effect on hours worked or earnings. And so it seems as though LA is protective in some way against these negative effects of PC. These for the most part go away afterwards. And so this is kind of a transitory effect that we're talking about. You see a similar pattern when you look at other socioeconomic outcomes. And so here, like here's per capita consumption is negative for people in the PC arm, that's the blue, but then it's 0 for people who got PCLA. So this pattern sort of shows up and then it goes away in the long term as well. So the same sort of thing. And then finally, for this paper, finally, we look at potential pathways. And so here we look at risk attitudes, cognitive performance, subjective well-being, and participation in household decisions. And a lot of the times we don't find significant effects. And these are useful because they also help us rule out that these were important channels generating relationships such as the one with child human capital. But what we do see is the significant increase in risk intolerance that's happening for people in the PCLA and PC arms after the intervention. And so the way this is measured is in terms of, are you willing to take actions to prevent yourself from experiencing negative shocks? So do you wear a helmet when you ride a motorcycle? Do you, how quickly do you take your child to the doctor if they're sick? And as well as, there are actually several other ways that we measure that as well, but that's the kind of intuitive idea. And this is showing that people are becoming less risk tolerant if they get the mental health treatment. So an implication of that would be that you take fewer risks. And so we actually can look at whether you take fewer risks based on whether you experience fewer negative economic shocks. And so we ask, have you experienced shocks like a fire, a flood, a divorce, being incarcerated in the past 4 months? And we actually see that there is consistent with this risk result, there is a decrease in the extent to which people experience negative economic shocks. And so this is interesting because it suggests another pathway, and it's painting a picture of how these results for education and risk and these negative shocks could be related. And so the way I would interpret it is this. First, we can rule out a few things. There is not evidence of a productivity pathway. It's not that these interventions are making people work more. And there's not evidence that their cognition is improving. In fact, we see that cognition goes down, which is something of a puzzle that we don't have a great answer for. But what the results for risk intolerance, as well as the human capital and the shocks suggest, is that what may be happening is that people are the symptom of depression, which is anhedonia, may be abating because people are getting depression treatment. And so from an economic standpoint, the way we would think of anhedonia is like if my utility function is flat. So I don't receive a lot of pleasure from gains from increases in consumption or improvements in my life, and I don't receive as much disutility from things that make my life worse. So I'm kind of just indifferent. So if that symptom is pervasive, it will make people answer the questions about risk intolerance such that they will look like they don't really care, right? I don't need to bother to wear a helmet when I ride a motorbike because I don't care if I get hit by a car or not, what's the difference? That's the sort of mentality. But that same mentality says, I don't really care if I make sure my child goes to school or does their homework because what's the difference? And so if depression treatment ameliorates that, then it could make people have steeper utility functions, which then make them express more of a preference for not experiencing negative shocks, as well as investing more in their children. So that's a possible interpretation of the results that we see. Although, I'm really speculating at this point. We can't really definitively say that this is what is happening. And so I want to just summarize with a couple of points about this, which is that we are studying depression treatment. And so there's always this challenge, which is like, you'd like to know what's the effect of depression on these things. But what we can't really sort of induce people to have depression in a randomized way. What we can do is offer people who are depressed treatment in a randomized way but the treatment versus depression are not necessarily the same thing. And so this is like particularly comes up when you think about cognitive behavioral therapy. That is, like think of what is involved in that is helping you plan, helping you think through your problems logically. And those are things that we would all do well with. They aren't just things that like help people with depression. And so when you study the impact of cognitive behavioral therapy, you're getting this bundle of all these things, one of which is less depression, but also these other things, also these other good things. When we think of pharmacotherapy, the same problem is present, but perhaps to a lesser degree. I mean, it's sort of, maybe you would argue with that, but I think in any case, it's different, which is pharmacotherapy alleviates depression, but may have side effects. The side effects are typically things like reduced sexual desire. And we don't see that a lot of people are experiencing side effects in our study, but you see that anyway. In any case, the ancillary effects of these treatments are different across pharmacotherapy and psychotherapy. And so there's a study by Baronoff et al., which is another economic study of the impact of depression treatment, but they're using cognitive behavioral therapy, and they're seeing also effects on child human capital investment. And so that sort of suggests, like across these two different approaches, you're seeing similar patterns, and the ancillary effects of treatment in these two cases are different, which may suggest that it's actually the alleviation of depression that's related to this. And then I guess, in addition, this BOT paper I should flag as well, which is a similar study using cognitive behavioral therapy and studying economic outcomes. And they also find effects on preferences. And so just like we're finding effects on preferences with pharmacotherapy, they're finding effects on preferences with psychotherapy. So these are really two channels through which depression could influence intergenerational poverty. And so if depression reduces child human capital investment, that means that children grow up to have less economic opportunities, lower earnings, and kind of contributes to intergenerational poverty. But the channel of the negative economic shocks is another one through which depression could influence intergenerational poverty, because a big reason why households remain poor is because they experience shocks that keep them in poverty. And so if someone can avoid losing everything to a flood, or to having a fire burn their house down, that sort of thing, then they will over time accumulate wealth more quickly than someone who experiences those shocks. And so if depression means that you expose yourself to more risk, then that also will contribute to people remaining poor. So I want to now just spend the last few minutes talking about another paper that's using the same data and the same trial, but is looking at another related question. And I think this is related in that, like, it also helps us to get at some of the mechanisms that may explain the linkages between depression and poverty. And so it's shifting gears a little bit in that I want to think about the fact that there is low demand for a lot of health products in developing countries. And so this is a known thing, that is, if you try to sell people soap or improved cook stoves, or deworming medication, people aren't willing to pay very much for it, and the elasticity of demand is really high. This has been documented across a lot of studies, and this graph is from Dupont and Miguel, and they've just charted demand curves for all these different goods. So you have vitamins, water filters, soap, water purification, across all these goods, and you see these demand curves all have this property where if you start charging people a little bit, then the demand drops off. And this makes it hard for policymakers, because you would like to recover some costs. Like, I'd like to charge people a little bit so then I can offer the product to more people. In addition, there's low correlation between product use and willingness to pay. So I can't kind of see, oh, people who are willing to pay more are going to be the ones who want to use the product the most. That isn't true. And so it makes it really hard for policymakers to target these products. And there have been many explanations that have been put forward for this, including liquidity constraints, information, or behavioral biases. And what we want to argue is that depression is another potential reason. And again, let me go back to the symptoms of depression that I've talked about. So anhedonia could reduce the utility of adopting a new product, a new technology, such as a health product. Pessimism about it might affect your perceived utility of buying this product. And indecisiveness may make it so that you have a hard time deciding whether you should adopt this product or not. And so again, the symptoms of depression may influence this choice. And this isn't something that kind of economists have thought about previously. So we want to ask here, does depression affect the demand for a novel health product? And if so, which pathways may be important? So in the context of this trial I already described, we also cross-randomized free provision of hand sanitizer. Hand sanitizer is the novel product. It was not commonly used by people in this setting before we came along, although it was available in the market. And it's important from a public health standpoint in these settings because a lot of people don't have access to clean water and they may not be able to wash their hands. And so it's a good substitute for soap when people don't have an ability to wash their hands with soap. And so we gave people free hand sanitizer, some of them, and then we measured the use of the product after 6 months when most of the free product had not been depleted. And then several months after that, we measured willingness to pay, and we did it using the Becker de Groot-Marschalk mechanism, which is a mechanism that's popular with economists because it elicits an incentive-compatible willingness to pay for a good. And so what we see is, in fact, that there is a relationship between depression treatment and willingness to pay for hand sanitizer. So people who got depression treatment, and here I'm changing the language a little bit. Before I was talking about PC as pharmacotherapy, here I'm calling it depression treatment. This is the same thing, except I'm also bundling people who got the PCLA and PC, and that's all depression treatment. And so this increases willingness to pay for hand sanitizer by 5.4%. And if you want to kind of put a number on this, it would mean that taking someone who had major depression and removing their major depression would increase their willingness to pay by 26%. However, depression treatment does not increase the use of the product under free distribution. And so these two findings actually are useful because they help us pinpoint what could be going on and why depression might be reducing the demand for the product, and help us understand better what are the mechanisms through which this could happen. So we can say it's not due through an increase in the earnings of the people, because I showed you already that didn't increase. We can explore whether giving people the product for free increase their learning about the product, and we find that it doesn't, and it doesn't matter whether they're getting depression treatment or not. But results are consistent with an effective depression on decision costs. So a lot of the pathways that you would expect would think of would cause both of these use and willingness to pay to increase in tandem. If I value the product more, then I should be willing to pay more for it, and I should use it more. And so the mechanism that makes the most sense for why we see this pattern is that depression makes it hard for people to make a decision about, do I want this product and how much am I willing to pay for it? And that isn't present when you think about, should I squirt some of this stuff on my hand or not? Is, the decision costs are much lower there. So this is the product. It's just, hand sanitizer, which and we measured willingness to pay for this. If I won't go into how exactly that works because it's a little complicated, but it ends up with each person giving us a value that they place on the product. And then to measure use, we ask them, how much are you using the product, which is the obvious thing, but then we also asked them, we also observed how much of the stuff we gave for free was still around. And so that's a more credible measure than just asking people if they used it. So here are the demand curves for people in depression treatment and not depression treatment. And so you see there's like this red line is that the demand curve is shifted out for people who got depression treatment relative to people who didn't. And so that's the main result. But then when you look at use, these are cumulative density functions of how much hand sanitizer they had left. And you see that after 6 months and then also after 12 months, they're right on top of each other. People are not differentially using the product more if they got depression treatment. And so then we think about the pathways that could explain this. As I said, we can just say, did their earnings increase due to depression treatment? And we see that that's not the case. We can see whether there's an interaction between free distribution and depression treatment in terms of their learning about the product or their use of the product, and there is no effect there either. When we think about a possible effect on preferences, such as the anhedonia story I was talking to you about before, that doesn't seem to explain what we see here, which is that there's no impact on other health-related consumption. It's not that people just value their health more because of this. And the fact that there's differential effects on willingness to pay versus use is also not consistent with just greater marginal utility of hand sanitizer. But what it is consistent with is decision costs, that I have a hard time making decisions about whether I should buy this product or not, and if I'm depressed. And then when I've alleviated that through this depression treatment, people are more easily able to come up with a valuation for the good. And another kind of neat result that supports this is that we also measured willingness to pay for a packet of biscuits, which is not a novel product, something people are very familiar with. And here we don't see any effective depression treatment on willingness to pay when you look at a non-novel product. And so just to conclude this discussion, I want to just highlight some of the policy implications of this. There's this big debate about free distribution versus cost sharing and how best to target goods to people who are poor or who have high demand. And if people who are depressed exhibit low willingness to pay for products, then that means that they're not going, you can't sort of ask how much do you value this and then give it to people. If people are depressed, they're not going to answer that they value something, even if they would turn around and use it if you gave it to them. And so it sort of creates this complicated situation for policymakers. In this setting, giving product for free may dominate cost sharing. By trying to charge people a price, you're going to make them experience these decision costs that make it so that they say they're not willing to pay, and you just don't really distribute it effectively. If policymakers are trying to design distribution approaches that reach people who are having psychological distress, you want to minimize psychic costs. So don't make it so people have to think about whether they want it or not, and also avoid ordeal mechanisms, which means like giving you a voucher that you have to show up at 3 p.m. on Thursday to reclaim your product or something like that makes it more challenging, because those are going to differentially screen out people who are having psychological distress. So in the case of, I think across goods, it would vary how you would do this, but in the case of hand sanitizer, you could imagine that for a fixed budget, instead of giving everybody hand sanitizer for free to keep at their house, you could spend the same money to install little sanitizer stations in front of latrines. And that would be a way of kind of, giving people less without charging them and imposing decision costs on them. And so I guess that's all I really wanted to share today. I think that in summary, what we see from this research is linkages between depression and the way people make economic decisions, and that these are related to the symptoms of depression that I talked about. The anhedonia or the indecisiveness affects how people make decisions in ways that may contribute to the perpetuation of poverty across generations. But this is a very new a research area. There isn't very much on this, and so it's a frontier where we still don't know very much, and much more work is needed. So thank you with that. Thank you so much for your attention. I'd be happy to chat further or take your questions.
Okay, thanks, Daniel. Thanks for sharing your very insightful and policy relevant work. Like you mentioned, it's like shocking to see that like depression and mental health is such a large issue in developing countries, but so far we know so little about it. So for our audience, if you have any questions, please, you can enter them in the chat box, or you can also raise your hand. I just see your hand.
Thank you, Daniel, for a very interesting study sharing. I noticed that in your first part of the presentation, where you showed the pharmacotherapy impact or intervention seems to be greater than a combination therapy. I don't follow the logic. I would assume that when you add the social assistance program on top of the pharmacotherapy, it should at least had no negative effect, right? But the regression table indicates the combination effect seems to be even less than a single therapy.
Gordon, which outcomes are you talking about?
The regression table. Can you?
So there's the schooling one here.
That's right, over here. You see the PC intervention achieved 0.19, right, to some level of significance, but the PC plus LA, achieved almost no effect. Why is that?
Mm-hmm. So I think that first, these aren't significantly different, and so I would hesitate to interpret it as, well, this was bigger than that, because we can't reject that those are the same number.
But for what about for the cohort of child age greater than 12? You see, you also obtained the similar pattern over there. The PC intervention achieved a greater effect than the combination. So I don't follow it.
Yeah, no, I mean, I don't know exactly. I think that we should do more research on this, and I think that that's what we hope to do to try to tease this out. Again, I think even especially in column 5, these PCLA 0.42 is not significantly different from PC 0.46. Those are similar estimates, and so yeah, I mean, I think, but I take your point, which is that the PCLA had a bigger effect on depression than PC, and yet the impacts on education are similar, and so it suggests that maybe there are other reasons why these interventions are improving education other than just depression treatment. I guess that is fair, and I don't have a better answer for why exactly. We just need to keep studying this.
Is it possible that the LA intervention triggered their cognitive capacity, so that I don't know, because the LA intervention would have to interact with the individuals, right? While the PC just give them pills. So does that
I'm not sure I understand and that part, but I think that the way I think about the LA is that if you think about this from the standpoint of stigma, I think this makes a little bit of sense, and maybe not these specific results about education, but why the effects on mental health are bigger, because you don't want to be labeled as the person who has a mental disorder, and having the LA intervention present means that you can say to your friends that I'm participating in this study because I'm getting this training and this loan or whatever, this extra thing. It's like a fig leaf that makes it so that you have the deniability that you're doing this because you're sick. And otherwise, the kind of pharmacotherapy or other psychiatric treatment has this aspect where I'm diagnosing you as having a medical problem and I'm going to treat you, and that diagnosis is bundled with treatment, and that is just a part of how treatment is typically given, and that could have negative implications that offset the benefits of the treatment.
Right. That's possible. Yeah. Thank you.
Yeah, you're welcome.
Yeah. Thanks, Professor Liu, for your question. So if I can just probably quickly follow up on that, also combining one question from our Q&A from the audience. Can you tell us a little bit about the backstory about how you choose the PC and LA? When you include the LA in the treatment, do you have that it could alleviate the stigma concern in mind? Is that why you choose it? And also, have you done something like the cost effectiveness analysis for this treatment? Because like you mentioned, there could be a zillion things you could do with this type of mental health issues, right? And that's the question from our audience. Yeah.
Great. So how did we choose? So when we started this, we were working with an NGO called Basic Needs, that is an international NGO that provides mental health care they have affiliates internationally, and their model is that you provide both of these things. And so we were trying to test their model, and so we provided both of these things. I think the theory behind that is that you need to improve their socioeconomic position of people so that they aren't experiencing the same risk factors for psychological distress that they were before. So get them into a stable environment where they have a regular income and they're not as worried about, I don't know, like starvation or not starvation, like, extreme, like immediate concerns. And so that's, I think, the model. I don't know that that's been, like is based on evidence. I think it's more of a concept that they have, but the NGO, so we didn't end up, Basic Needs ended up separating from the NGO that we ended up working with. And so they weren't, involved in the study in the end, but that was where the concept of providing both of these things originates. And so let me talk about the cost effectiveness. So yeah, I was skipped over that due to time, but the cost of PC is about 200, and as implemented, as is like $280 or something per person. And the cost of LA is $15 per person. I might have those numbers wrong, but it's on that order of magnitude. And there's a table in the back of the paper where we do this exactly. And so you look at, if you think of like the cost effectiveness in terms of improving mental health, it's clear that bundling LA with PC is cost effective because it doesn't cost very much to do that. It's it's very light touch, and it magnifies and extends the mental health benefits. And so that's something that I think is another takeaway from what we see, as well as it has those other benefits in terms of alleviating the short-term negative consequences of pharmacotherapy.
Right.
So can we have a reference if this research has been published? So if you're talking about my this paper, it's in economics, it takes forever to publish, so we are still working on that, but it should probably in the next year the first paper will be published, hopefully. And both of these papers are available in working paper form on my website, so you could go look at those there.
The question from Dr. Danish.
Thank you, and hi Daniel.
Hi.
Fantastic presentation. So I'm joining you from Australia, Canberra, where it's actually the 3rd. So in a sense, I'm calling you from the future. Now,
Amazing how that works.
quick comment on the study. Having worked in India myself, certain factors such as gender and area of residence also have an impact on depression and socioeconomic status. And I wondered what your thoughts on that were. And separately, if I may quickly ask, in terms of the relationship between pharmacotherapy and the results on the earning and the time that you'd shown before, it may be possible that there is an opportunity cost for participants to get pharmacotherapy, as they may have to go to a health facility, and that may take time away from potential work. So I just wanted some thoughts, but really great presentation. Thank you.
Thank you so much. Those are great comments. So I think the second thing first is that I agree that part of, if we say that there's like a reduction in the amount of work time, there's just a mechanical effect of I'm spending more time going to the doctor, and so I have less time to spend working. The actual appointments happened on Sundays when they wouldn't have been working anyway, and also the amount of time that they spend working compared to the amount of time in the appointments is not really comparable. And so I think that's not really what's going on when we see the work time going down for some of them. In terms of the gender and area of residence. So gender is a big thing that I think I should have touched on more. So thank you for bringing it up. So we didn't stratify by gender. And so depression is more common among women. And also women are more likely to be home when you come around and try to recruit people for a study during the day. And so as a result, our sample is, I believe, 86% women. And so that may help us understand why we don't see labor market benefits of the interventions, because we tried to identify people who were willing to work, and that was a screening criteria, was, are you willing to work, or do you already have a job, do you have to take care of children during the day? And so we tried to identify people who are willing to work, but still there's a lot, female labor force participation in India is low, and so if a lot of those people are going to be reluctant to actually go take a job, and I mean, I think that may help explain why we don't find effects. But if you look at the meta-analysis that I talked about at the beginning of economic outcomes, they are finding effects of mental health treatment on work across other studies. And so that would be that's kind of another consideration. And I think in future work, we would like to stratify by gender better, because having it be mostly women means it's hard to compare and say, this is different for women versus men. And, if we had a bigger sample of men, then we would be able to do that better.
Yeah. Thanks, Danish, for your question. And also that's actually one of the questions that I have in mind. So like in your paper, you also mentioned that the bidirectional causal relationship between poverty and mental health, right? So your work of your finding of no impact on earning and wages and work or anything is not kind of ruling out the causal relationship between mental health and poverty, right? So it's just that probably this is a particular sample, or you're observing them within a particular time period. If we have a longer time horizon, and if we're doing it in a different sample, probably we're going to find something causal relationship between. Would you think that is true?
I think I suspect if you looked at men, you would find more of an effect. But I don't know that because we haven't done it yet. And I think that even if there isn't a labor market kind of contemporaneous effect on earnings of depression, the other results for child human capital and for experiencing negative shocks could contribute to poverty in an intergenerational sense. And so it's not just I'm depressed, I don't work as much, I'm poor. It's I'm depressed, I don't invest in my kids, and they grow up and they're poor.
Yeah. Yeah, I think that's kind of a novel finding. I think we don't have much evidence before about how your mental health would affect the investment in children, right?
I mean, I think there's a correlational literature about this, but there are only a few studies that are RCTs that are in developing countries that are showing this. And the Baranoff et al. Paper I mentioned is one that does this as well, but with psychotherapy instead.
Yeah. So I wondered, since it's an experiment, you have done a lot of field work, and I wonder, again, related to many things you can do related to this mental health issues. Do you during your field work, have you are there anything that you think will be very valuable for people to try and improve this this kind of scenario? For example, some of the binding constraints basically in solving this issue, right? For example, there could be provider quality or the stigma. Are there any stories that you can share when you try to conduct this experiment? And you think it's very important for future researchers to address?
So I guess I'm trying to think of how to answer your question. I guess I'll tell you about one pattern that we've seen in the data that we haven't written up, but is intriguing to me, and which is about the relationship between the depression treatment and marriage market outcomes for the other people who live with the study participants. And so here, India has an arranged marriage institution, and so there's no courtship. And so there's the way marriages happen is through families matching with other families, and the bride being transferred to the groom's family. And so that's a situation where there's a lot of asymmetric information, is what we would say, where you don't know what the quality of the person is. Because there's, normally in courtship, the people date and they get to know each other and they decide it's a good match, but that doesn't happen in this setting. And so then like that puts a premium on like being sure that this is a good family. And so if any kind of aspersion that maybe this family has problems will make it so that it's harder for you to get married. And so being a family where there's mental illness is bad from the standpoint of the marriage market, right? Like you're trying to find a match for your daughter, and yet someone in your household, not her, but someone else is going through this trial and is getting depression treatment, and it makes it look like maybe there's just depression in this family. And so what we see is that in fact people who were in the same household as the people who are getting depression treatment are less likely to be married at follow-up. And if they are married, they are the husbands are worse, meaning like they have less education, so that like the quality of the matches is worse as well. But this is only true for women. And so for men, this penalty isn't there, which also I think is like, if you talk to people, like as I've talked to people about this and said, does this make sense? And they say, yeah, of course, like there's like a lot of gender discrimination in India, and this kind of the stigmatization of mental health falls especially on women. And so, that's a result I hope to explore further, and kind of is intriguing to me, but it shows that the kind of ramifications of mental health kind of may show up in these unexpected ways. Like who would have thought that it's like affecting marriage for other people in the household,
Right.
Not even the person who's depressed.
Yeah, that may also suggest, like you mentioned, the stigma is really a big thing in this context, right? And so I don't know, probably if like someone wants to do some other intervention to address the mental health issues, I think the stigma might be, right? Probably for some future research. Yeah. I think, I don't think we have more questions from the audience, and we are also at time. So thanks again, Daniel, for sharing your research with us. And thanks our audience for participating, and hope to be in touch with you for future webinars. Thank you all again. Have a good rest of your day. Thanks.
Thank you so much.